think you'll find this session a provocative session with some of the topics we all deal with as surgeons, specifically with some of the issues that the American College of Surgeons is focusing on currently, including the Palliative Care Initiative, the Geriatrics Initiative, and social media. We have an excellent panel of discussants who will be up here. So if I could ask the rest of the panel to come on up to the top and have a seat. I think it's just probably Sean, Chris Kokenaar, and Sharmila Disseminating are both virtual. But we'll go and get started. Our first speaker is Bridget Faye, who is a professor of surgery and medicine at the University of New Mexico, where her surgical focus is on surgical oncology, really specifically focusing on colorectal surgery from that perspective. She's one of fewer than 100 surgeons in the country that have their boards in hospice and palliative care medicine, and that's been kind of a focus of Bridget's ever since then. She's also the director of surgical palliative care at the University of New Mexico, and today she will be discussing palliative care and surgery. Bridget.
Thanks, Rob. So it's anyone that's ever heard me talk about palliative care, if you haven't been to church lately, it's happening. This is like something I'm super passionate about. And I think that what you will find is that this is really probably, hopefully, will resonate with what you deal with every day in your practice. And the title that I've given this is Palliative Care is Good Surgical Care. And that really comes from Jeff Dunn, who is the father of surgical palliative care, certainly for the American College of Surgeons and really in North America. So by the end, we're going to talk about the role of surgeons in providing palliative care, defining core competencies in surgical palliative care, and then really talking about what the American College of Surgeons Committee on Surgical Palliative Care is working on. And hopefully I will stimulate you to think about kind of ways where you might be able to integrate these principles into your own practice. So really this work dates back now for a couple of decades, but Jack's had an inaugural series on surgical palliative care back in 2001, and kind of a little bit of the history. Really, this came up with the whole medical aid in dying or physician-assisted suicide, where this was a huge topic in kind of the late 90s, and people wanted to know what surgeons were going to do about it. And so this quote by Jeff Dunn and Bob Milch talks about really why the surgeons should even care. And they said the widening spectrum of disease and life expectancy encountered in palliative care led to the inevitable arrival of the concept at the doorstep of many specialties, including surgery. And that's our significant presence in the setting of advanced and incurable illness. Surgeons could not indefinitely avoid the social, psychological, and spiritual challenges incorporated there. So basically we could run, but we could not hide. We were going to have a voice in this discourse. So again, this is a picture of Jeff Dunn, who is really, like I said, the father of surgical palliative care and was the inaugural member of the Palliative Care Task Force. He wrote a really nice review just recently about the history of surgical palliative care, and he said it was really dating back to the late 90s when the ACS said we have to really be advocates for palliative care for our patients and their families, and those with serious, critical, and terminal illness that were undergoing surgical care. The primary catalyst for this recognition was really the surgeons to identify. We were the ones, the US surgeons, to say, yes, this is a real specialty. This has to be a real thrust of our practice. And the focus has really been through educational efforts that are directed at both practicing surgeons as well as surgeons in training. And finally, you'll hear palliative care is a team sport. So the fellows of the American College of Surgeons were really supported by leading non-surgical pioneers in the area of palliative care. And these have been important partners, essentially paving the way for some of the early surgeons, but also this coalescence of what non-surgeons need to know about palliative care, and then what could surgeons lead from their non-procedural colleagues. This is sort of a very rough timeline dating back to 1997, where at the Clinical Congress, they had this colloquium on ethics, and it was about end of life. And again, it was really associated with this physician-assisted suicide question at the time. And then you can see as we go down in 2000, there was one of the other important symposiums, Palliative Care by the Surgeon, Patient Selection and Management, starting to make this not such a theoretical discussion, but really more of a practical one. Then in 2003, the Robert Wood Johnson publishes its report from the field about surgical palliative care. Importantly, when you come down in 2006, hopefully everyone knows the importance of Olga Jonassen to the American College of Surgeons. At that time, she was the director of the Division of Education, and it was at that time that the actual medical specialty of hospice and palliative medicine was initiated by the American Board of Medical Specialties. And Dr. Jonassen, along with the American College of Surgeons, said, we want a seat at the table. We want to be one of the 10 sponsoring boards. And so for those of us that are boarded in hospice and palliative medicine as a surgeon, we get our board through the American Board of Surgery. And then you can see there have been, continuous years of dedicated symposia related to surgical palliative care at the Congress ever since. So we went from a task force to a work group, and then just in the last several years, we've become the Committee on Surgical Palliative Care, and that has importance if you work within the structures of the American College of Surgeons. Essentially, our mission is to incorporate the precepts and the techniques of palliative care into surgical clinical practice, education, research, and advocacy, and I'll kind of touch on each of these in just a bit. So I wanted to kind of flash up some of the folks that are key members of the current American College of Surgeons Committee on Surgical Palliative Care. I'd point out Ann Mosenthal, who's our chair, who is now at the Leahy. She was the chair at Rutgers for a number of years. Hopefully many of these people look familiar to you, and I point them out in part to show that kind of the diversity. We have those, of course, that are in trauma, acute care surgery, some important members from the general surgery community, a couple of colorectal surgeons, and then myself and some of my other colleagues from the oncology community. So the point is, we really are trying to fan out and talk specifically about the role of surgical palliative care within surgery and then within the subspecialties. So really, again, what is palliative care and what's it got to do with you as a surgeon? Well, Jeff Dunn and the task force, or the Committee on Surgical Palliative Care, published these guidelines. These are the statement of principles of palliative care, and it really became the roadmap for what are going to be the core competencies. And you can see it really starts with being an advocate for our patients to choose both curative and non-curative therapies. So just because we may not be in an opportunity to cure our patients doesn't mean that we don't still have something to provide. The foundation of this is really communication. We have to know the best care for our patients by knowing what their goals of care are. We are never choosing between treating their disease and alleviating their pain and non-pain symptoms. These things go together. We have to acknowledge that our patients come with more than just their corporal bodies and their physical pain, but their diseases happen in the context of their communities with psychosocial, spiritual, and psychological needs. Again, knowing whether or not to offer an operation, we had a nice discussion about whether or not to take out and do interval appendectomies. Well, we have to know whether or not these procedures are consistent with the patient's goals of care, and that means you have to actually ask. We also want to alleviate the sense of abandonment. So I think one of the things that I've always appreciated as a surgeon, particularly a surgical oncologist, is I'm there at the time of diagnosis. I'm often the one making the biopsy. And I really think it is our job to be there for the continuum of care, even into end of life care, that we are there from the beginning to the end. So again, these principles of surgical palliative care have really been distilled down into some core competencies. And what Jeff Dunn has written about many, 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 many times is that these are core competencies. This is just as much as what size blade, what size suture, and what surgical approach to take to disease. This is also part of the toolkit that we have to bring to our patients. It's both assessing and treating their pain and other symptoms. We're communicating effectively and compassionately, and that includes breaking bad news. That's being the one who says, this is not a survivable injury. That's I'm sorry, we're going to have to do an amputation if this is, end stage peripheral vascular disease. This is a trauma patient whose life has changed irrevocably after their injury. We have to be able to conduct patient and family meetings to really understand what is that patient and their family, what are they hoping for, and where do our surgical interventions, how do they align with that? We need to be able to perform palliative procedures competently and with sound judgment. So that means, in the words of Murray Brennan, do not promise what you cannot deliver. That means, what are the real goals? What can I offer you with this operation? And that includes the good and the bad. Am I going to alleviate pain? Am I going to cure whatever your problem is? And at what cost? And then we also have to exercise sound clinical judgment in both the withdrawal and the withholding of life support. And for those of you that do critical care, you're standing at the bedside deciding now, particularly in the time of COVID, who gets the vent, who comes off the vent, who's going to benefit when times of scarcity of resources. So this is really what is called primary palliative care. And this was written by Timothy Quill and Amy Abernathy from the palliative care world, saying we can't all be boarded in hospice and palliative medicine. I'm sure many of you that have finished training never want to go back and do more training. So, but these have to, again, be skill sets that you're bringing to the bedside every day. So it's basic management of pain and symptoms. You have to be able to do some assessment of depression, anxiety. I'm not talking about sitting down and doing psychotherapy with these folks, but at least acknowledging how their psychological state is going to impact their response to their illness and their recovery. And then being able to have some basic discussions about prognosis, goals of treatment, suffering, and their code status. So it is fascinating how many times I go as a palliative care provider and look on and see a surgical patient who has no code status note. We haven't identified the surrogate decision maker. Nobody really knows who this person is, but they're on the train, right? You're in the unit, you're on the vent, you got some pressors going, maybe a little CRT on the side, and then no one ever stopped to say, is this what this person wants? Who is this person? What's going to be important to them? So this is us. This is what each of us needs to be able to provide. And now we'll talk some about what some of the current initiatives are. So the Committee on Surgical Palliative Care resides within the Division of Education, which has really been led ably by Satch for many years. And he's been just a stalwart proponent of palliative care and an important ally to support our efforts. This was the Resident's Guide. For those of you that haven't seen it, this is a free product that's available. It's on SCORE for those of you who are involved in surgical education. You can see here it was actually published in 2009. I'm happy to say that we're working on a new version because there is a body of literature now that's expanded in the area of palliative care in general and specifically surgical palliative care over the years. I don't mean for you to read this list, but this is just showing you that at the Clinical Congress, there are always a number of palliative care related topics that are discussed. In this coming virtual year, I'll be speaking on safe and effective pain management. There's obviously a lot of focus on opioid sparing strategies for the surgical patient. The next is integrating palliative care into surgical care. This is not what you do when there's nothing left to do. This is the formal integration, the bringing palliative care on board. So this was an early article. Many of you know Karen Brazel when she was in Milwaukee at the time, looking about accessing palliative care and patients in the surgical intensive care unit. You might recognize these characters. So I wrote a chapter here about palliative care in the acute care surgery setting. This was an article by Emily Reve, who's a colorectal surgeon and also a palliative medicine provider at Virginia Commonwealth. Here's another recent series, actually, of the surgical clinics of North America that Anna Berlin wrote about. And then even most recently, Zara Cooper's a critical care trauma surgeon at the Brigham, who talked about you really can't be taking care of coronavirus patients without embracing palliative care. Then the next initiative is really what are the quality metrics for palliative care in the surgical patient? So TQIP has a best practices now. The key messages out of that TQIP or those guidelines are that palliative care is delivered in parallel with life-sustaining trauma therapy, considering that patients who are injured come again within a context, so their family is also the unit of care. There really should be palliative care consultation if possible, but this is, again, back to that core competency of the trauma surgeon and the trauma team providing primary palliative care. It's an interdisciplinary team sport, again, acknowledging that patients come with spiritual and emotional and psychosocial needs. And then you have to have some basic competence in symptom management as well as goals of care and end of life care. And what they say is here's a little bit of a roadmap. In the first 24 hours, you need to do an assessment. Does this patient have palliative care needs? Is this 2 rib fractures in a 24-year-old, or is this somebody with a traumatic brain injury where the prognosis for recovery is very limited? And then they have a screening tool, and it just says you got to start talking to people early so they don't get on that train and can't get off. In my own world, in the world of oncology, it was not until 2012 that the Commission on Cancer actually had a palliative care standard. And so that has since been revised. Now it's standard 4.5, and it says that you have to have palliative care services either available or on site. Patients need to be evaluated at least once per year. You can imagine cancer is not a static process. Where you're at the time of diagnosis is different than if you're having recurrent cancer. And again, it really has to be delivered at the beginning or at the time of diagnosis. The Commission on Cancer, God bless them, hopefully we don't have any officers here, really have had a really hard time disengaging palliative care and hospice. And I think we are finally getting the message out that it's not just hospice care, that palliative care is provided concurrent with curative intent therapies. And again, it's really best provided as a team sport, so that primary oncologist, surgical oncologist included, providing palliative care, and then consulting the palliative care team when needed. And again, these are just some of the different palliative care services that need to be provided, including things like addressing spiritual needs, talking about prognosis. And then in the area of research, this was a nice article written by Dr. Lilly and her colleagues and Ann Mosenthal, talking about what are our priorities in the field of surgical palliative care. First, we want to measure those outcomes that matter to patients. And it's probably not a 1-point increase or decrease in some quality of life scale, but it really is some measurable outcome that's important. We need to talk about what are the effective communication tools that help with shared decision-making. How do we deliver palliative care to our surgical patients? And I'm happy to say that while there have not been a plethora of surgical palliative care trials, this is a trial that I'm fortunate to be the site PI on, funded by PCORI, looking at perioperative palliative care concurrent with curative intent for gut and hepatobiliary malignancies. The study will close in about a year or so, but really the first of its kind, a surgical palliative care trial. And then also in the field of research, this is an opportunity. Hopefully I've got some learners in the audience. We're having our 5th annual Committee on Surgical Palliative Care Symposium. It's going to be on Thursday, November the 4th at 7 to 8 Central Time. And this is an opportunity where we present works in progress related to palliative care, things that are innovation, outcomes related research. There we'll have some updates on what the committee's up to, networking opportunities. This is where I met my current Sir-Jonk Fellow, I'm happy to say, and recruited her into my Sir-Jonk Fellowship. And then there's some information. You can always contact me for that information as well. But again, on the 7th, so you still have a few days to get your little abstract together. And then we'd love to have you participate. It's a very informal group, but with some good, robust discussion. So, and then last in advocacy, this is maybe one of the most important things I've done in my professional life, which was to advocate for the ability of surgical residents to achieve board certification in palliative care during their surgical training. So much as you would go out for a research year, you can do your palliative care fellowship during your research year and then go on to get board certified. So in conclusion, the ACS has really had a longstanding commitment to advocating for palliative care for surgical patients and their families. Those core competencies I mentioned about pain and non-pain management, communication, performing palliative procedures, knowing when to withhold or withdraw life support when appropriate, of course. And then our current activities in the Committee on Surgical Palliative Care. Really, education is first and foremost, but also giving some practical tools about how do we integrate palliative care into practice, establishing those quality metrics, research and advocacy. I thank you so much for your attention, and let me know when you want to come back to church again, because I can do it again.
Thank you, Bridget. Our next presenter will be virtual. It's Christine Kokenayer. She's professor of surgery at University of California, Davis, where she is an acute care surgeon. There, she is also the medical director of the Surgical Intensive Care Unit and the past director of their Surgical Critical Care Fellowship. And now she is subsequently the Quality and Safety Chair for the Department of Surgery. Chris is also the past president of the Western Trauma Association and Northern California ACS. And today, Chris will be speaking about the Geriatric Certification.
Good morning. Thank you for inviting me to speak on geriatric certification. I have no disclosures. As I'm sure that all of you are aware, the US population is aging. More than 10,000 people turn 65 every day, and it will continue for the foreseeable future, as you can see from this graph. In 2019, those aged 65 and older represented 16% of the population, or 54.1 million people. This population is expected to grow to 21.6% of the population, or 80.8 million people by 2040, in less than 20 years. More than 40% of inpatient operations and 33% of outpatient procedures are performed on those over the age of 65. It was projected in 2000 that the frequency of colorectal resections would increase by 42%, primarily due to the increased proportion of older adults in the US population. Recently, Rubin et al. Looked at trends in the frequency of major abdominal operations between the years 2002 to 2014, examining data from the national inpatient sample. They found that adults aged 50 to 64 had an increase in overall numbers of major elective abdominal procedures adjusted to the US population, but was unchanged in those 65 to 74, while those over 75 had a decrease in major elective abdominal procedures. In emergent major abdominal surgical procedures, there was a decrease seen in all age groups, with ages 75 to 84 and those 85 and older having the steepest decline. For those 85 and older, there was a 43% decrease in emergency procedures from 2002 to 2014. Rubin et al. Also found an improvement in mortality for all age groups in both elective and emergent procedures. Using the Alex-Hauser score as a measure of comorbidities, they found that this score increased in all age groups undergoing emergent procedures. And in those undergoing elective procedures, the number of comorbidities was decreased in those under 74, but was increased in those persons 85 and older. They surmised that the reduction in case volume overall was related to significant advances in alternative therapeutic interventions and consideration of non-invasive or palliative treatment options. They attributed the reduction in mortality to a decrease in overall numbers of emergency procedures and improvements in perioperative care. But we are still doing surgery in the older population. Besher et al. Attempted to estimate the incidence and cumulative risk of major surgery in older persons in the US and to evaluate how these estimates differ according to key demographic and geriatric characteristics, including frailty and dementia. They calculated the overall rate of major surgery in those over 65 as 8.8 per 100 person years, with elective surgery at 5.2 and non-elective surgery at 3.7. As you can see from the graph, the rate of all surgeries and elective surgeries peaked in the 75 to 79 year age group. That was lowest in those over 90. Non-elective surgeries were highest in the oldest 3 age groups. The incidence of major surgery increased with worsening frailty, which was largely driven by an increase in non-elective surgery. The 5-year cumulative risk for major surgery was 13.8%, with a risk of 8.6% for elective surgery and 6.8% for non-elective surgery. The younger age groups had higher risk for elective surgery, while the older age groups had higher risk for non-elective surgery. We are obviously doing surgery in older persons and seeing them in our emergency rooms. As this population increases, organizations such as the American College of Emergency Physicians and the American College of Surgeons have recognized that we need to improve how we care for the older person. Both ACEP and ACS offer geriatric certification programs. ACEP has the Geriatric Emergency Department Accreditation Program, and ACS has its Geriatric Surgery Verification Quality Improvement Program. We will spend the rest of the time talking about ACS's Geriatric Surgery Verification QI program. It started out as in 2004 as the Task Force on Geriatric Surgery. It was created with the support of the American College of Surgeons and was composed of a multidisciplinary group of leaders interested in geriatric surgical care. The overall mission of this group was to improve the quality and safety of surgical care for all older adults in the United States and actively work to improve care for older patients through education, partnering, and advocacy. In 2015, the ACS was awarded a 4-year grant from the John A. Hartford Foundation to develop and implement a geriatric surgery verification and quality improvement program. This broad-reaching quality program was designed to systematically improve care and outcomes for the adult older surgical patient. Developing a quality improvement program centered on older patients undergoing surgery was driven by a number of factors, including, as we've already heard, the rapid growth in the number of Americans ages 65 and older. A team of ACS members with geriatric expertise and ACS staff worked with a diverse group of stakeholders that represented several health professions, patients and their families, and payers. They vetted these standards and contributed to the development of patient-centered outcome measures. Beginning in 2016, the core development team, advisory panel, and multidisciplinary stakeholder groups worked to set the standards for geriatric surgical care. This endeavor was done through a combination of extensive literature review, a series of hospital field visits, and meetings with engaged stakeholder organizations that rated the proposed standards on both validity and feasibility using a modified version of the RAND University of California, Los Angeles appropriateness methodology. The 308 standards were ultimately reorganized into 92 standards. The panel then invited 15 hospitals to participate in a survey to determine which of these standards were already implemented, or to understand how easy or difficult the standards would be to implement if they were not already in place, and to identify standards that were confusing or difficult to interpret. Following completion of the survey in 2017, this information was used to refine the standards further into a core group of 33 standards that focused on the following 4 areas: goals of care and decision-making, cognitive screening and delirium prevention, maintenance of function and mobility, nutrition and hydration optimization. From 2017 to 2018, the standards were presented, discussed, and pilot tested in 8 hospitals, representing a diverse geographic location as well as hospital types and sizes. Formal site visits were conducted by the core development team members, which included chart review, interviews with key team members, review of hospital processes and policies, and evaluation of certain physical parts of the hospital. The results of the pilot testing showed that each hospital was able to implement most of the standards. Several best practices for standard implementation were collected from the pilot sites, including the creation of a preoperative checklist for important geriatric surgical screening tools, the use of telecommunication to bridge the gap between hospitals and post-acute care facilities, and others. The information derived was used to help finalize the optimal resources for geriatric surgical care standards manual. In July of 2019, the ACS's Geriatric Surgical Verification Optimal Resources for Geriatric Surgery was released. The GSV program will help hospitals of any size prepare for the influx of older adults that are considering surgery by providing care standards that define the resources hospital will need to have in place to perform the operations effectively, efficiently, and safely in this very vulnerable population. The standards take into account that older adults have distinct physical and social vulnerabilities, as well as unique goals for their care that warrant a very thorough and individualized approach to the surgery. The standards outline processes for systematically improving older adult surgical care. It includes, but are not limited to, improving communications with patients before surgical procedures to focus on outcomes that matter most to the patient, screening for geriatric vulnerabilities, better management of medications, and providing geriatric-friendly rooms, and ensuring proper staffing is in place. The Geriatric Surgery Verification Quality Improvement Program provides a framework for the optimal care of the geriatric surgical patient and is generalizable to more than 4,000 facilities, regardless of their size, their location, or their teaching status. The development of the verification process is built on the belief that the use of these standards must be verified to build public trust and ensure success of the program, much as it has done with other ACS quality improvement programs, such as the trauma verification process and TQIP. The Geriatric Surgery Verification Quality Improvement Program resides with the other verification programs in the ACS Division of Research and Optimum Patient Care. Hospitals seeking a level 1 or level 2 verified status must demonstrate all 30 required geriatric surgical verification program standards that they must be in place to provide optimal resources for the surgical care of the older adult patient. A site visit conducted either on-site or virtually will confirm the hospital complies with the required structure, processes, and standards of care. This comprehensive assessment must be positively completed before a hospital is eligible for a GSV level acknowledgement. Verified hospitals will receive a formal public recognition at the granted level. Hospitals have the flexibility to implement the program standards across one specialty or even in multiple specialties, depending on the hospital's profile and the population requirements of the desired level. For a level 1 or comprehensive excellence program, the GSV program standards must be verified across one or more surgical specialties and must reach 50% or more of the hospital's total population of eligible surgical patients that are 75 or older. For a level 2, where it's focused excellence, the GSV program standards are verified across one or more surgical specialties and must reach between 25 and 49% of the hospital's total population of eligible surgical patients aged 75 years or older. At beginning level, the GSV commitment level hospitals are hospitals that are pledging to improve geriatric surgical care and working toward implementing the GSV program standards, and they're encouraged to enroll at this commitment level. Hospitals in this participation level will have access to implementation resource materials, guidance documents, leading geriatric experts, and GSV program staff aimed at supporting hospitals rolling out these standards. The commitment level hospitals will be guided by a self-paced curriculum that can be modified to meet each hospital's requirements. Although no site visit or verification of the standards will be performed at this level, hospitals are expected to be actively preparing the application for either a level 1 or a level 2 status within 6 to 18 months, up to a maximum of 24 months when they enroll at the GSV commitment level. The GSV commitment level hospitals will receive formal recognition of their commitment to providing high quality geriatric surgical care. These are what you would expect to see with the standards. Includes institutional administrative commitment, program scope and governance, facilities and equipment resources, personnel and service resources, patient care expectations and protocols that go over goals and decision-making, preoperative workup, postoperative management, transitions of care, as well as data surveillance and systems, quality improvement, professional and community outreach, and research. For further information on the Geriatric Surgery Verification Quality Improvement Program, I would refer you to the ACS webpage shown here. Everything that you need to get started on applying for verification can be found here. I would like to thank the Southwestern Surgical Congress for inviting me to present on this very worthwhile quality improvement program. Thank you.
Our next presenter is Jamie Coleman. Jamie is an associate professor of surgery at the University of Colorado School of Medicine, where she's an acute care surgeon at Denver Health for about another month. And then Jamie will be an associate professor of surgery and vice chair of wellness at the University of Louisville. Jamie has an interest and is really an expert in sleep deprivation, stress, and burnout. And today she'll be talking about social media and its impact on the patient.
Thank you, Dr. Todd, for the kind introduction, and to the program committee for the opportunity to present to you today. I don't have any financial disclosures, but I do have to say that I'm an active, albeit inconsistent, social media user, and I do hold a strong belief that our patients actually need us as surgeons to at least be aware of social media. We're going to talk about, and I'm going to share some stories and the real impact that it's had on our patients' health behaviors and their decision-making. We'll define social media and the demographics of its users, which I think is important. We'll describe the relationship between social media and our patients, and hopefully inspire you all to at least acknowledge the elephant in the room and hopefully engage with it just a little bit. Overall, I think many of us are aware that traditional media has had an real impact on patients. One such example is Katie Couric when she had her colonoscopy on the Today Show, and it had a real effect on patients, their decision-making, them seeking out, getting their colonoscopy, and to the point that it was actually measurable and published. Similarly, Angelina Jolie, she shared her story and her journey with hereditary breast cancer in the New York Times, which then led to an Angelina Jolie effect. Again, patients were not just listening to this story, but they were engaging it and bringing it into their own lives and into their doctor's offices and making real changes and real decisions about their own bodies, and actually led to an increase in preventative breast cancer surgeries. Now, these are positive impact stories. However, not all have been that way. I don't know if there are any UK football fans in the room, but this is George Best, who was an alcoholic and very publicly underwent a liver transplant. Unfortunately, although he had been sober prior to his transplant, he had a very public return to his alcohol use, and to the point that actually his surgeon who performed his transplant disagreed with liver transplants being done in patients with alcoholism, and actually then led to a measurable and noticeable effect or impact on the number of patients in the UK who opted for organ donation. Those were all traditional media stories, but what about social media? Here's one that I think we're all aware of, whether it annoyed you, you loved it, whether you got irritated because people kept tagging you in it. The Ice Bucket Challenge, which really took place over the summer of 2014, several years ago, mostly on Facebook. And regardless of whether you thought it was silly or not, raised over $100 million in the research or in research towards ALS and led to real research development. But if we step back for a second and say, okay, well, talking about media with social media, how is it different? And really, it's that, yes, they're both computer mediated technologies these days, and that a lot of traditional media channels are done via the computer, but it really goes to who is creating that content. And for social media, it's the users and the community themselves that are creating the content, sharing that information and ideas, and also forming virtual communities. We're going to come back to that in networks. Here are the platforms I think some of you are familiar with. There's Facebook, Twitter, Pinterest, LinkedIn, Instagram, Snapchat, WhatsApp, and of course, TikTok. I don't know what to say about that, but the average American uses 3 of these platforms, and they're using it a lot. Here's a graphic representation of the percentage of US adults who say that they use these platforms. Now, one of the things that I hear a lot when I talk about social media is, okay, Facebook, we know about it, it's a behemoth. Almost 70% of Americans use it and use it monthly and actively, with over 200 million active users every month. But it's really just for kids. It's just fluff. It's silly, you know, it's all entertainment. Well, actually 55% of the users at Facebook are over the age of 35, and 50% of all adults over the age of 65 regularly engage in Facebook. And this number is only just growing. In fact, it's more than doubled since 2012. Twitter on average has a slightly different slant or feel to it. It tends to be more business or news oriented, and it does have a slightly higher average age user with an average age of 39. But over 300 million tweets are published every day. The majority of businesses that have 100 employees or more are on Twitter. It is the #1 platform for government leaders, and greater than 70% of the users are using Twitter specifically for not just news, but for breaking news. YouTube. Again, a lot of people think, okay, it's just entertainment. Well, it's entertainment, but it's the second most visited website in the world with almost 2 billion monthly active users. 5 billion videos are watched every day. And the fastest growing demographics, unless you're a pediatric surgeon, are our patients. Fastest growing demographics are over 35 and over 55s. And in fact, YouTube reaches 95% of all adults with online access over the age of 35. I think one of the biggest things, again, with the advent of social media is that, well, again, it's silly, it's fluff, there's no role in medicine. And I'm here to tell you that regardless of what we think, this is really about our patients. 75% of all US consumers, and by consumers, I mean our patients, use the internet for healthcare knowledge and advice. Now, thankfully, WebMD has wonderful search engine optimization. And so luckily, not only is it a wonderful resource, but for patients who are Googling something, it does tend to come up as one of the first or second options to pick, thank goodness, and it is a very reliable resource. But you can see 1/3 of our patients are going to Wikipedia. People are going to Facebook, YouTube, completely unfiltered, not regulated sources of information. And so again, I'm going to tell you, 80% of Americans have a social media profile, and 80% of them are specifically looking for health information. 40% of them are looking for a specific doctor. In fact, the vast majority of your patients have Googled you before they show up in your office, whether we like it or not. And over 40% of patients are saying that information on social media specifically impacts which doctor they choose, which surgery they agree to, and which hospital they're going to have that surgery at. So again, whether we think it's important or not, our patients have not gotten that memo. And in addition to just trying to research their own situation or their own disease or their own surgery, this is where people are going for community. The 2011 study found over 620 breast cancer support groups. 25%, and actually that number is a little bit higher now, almost 1/3 of our patients with chronic medical conditions are using the internet to connect to other people. Whereas before, their community was limited to family, friends, people in their local community, coworkers. Now the world is so much bigger and so much smaller. They're reaching out to find people who are struggling and going through a similar journey to them. And I think this last piece of information scares me a little bit. I think it should scare most of us, that 90% of young adults trust medical information shared by others in their networks. These aren't just people that they know. These aren't people that they've met. These aren't people that they have their cell phone number, their coworkers, their classmates, they grew up together. These are people that they think they know. And to a certain extent, this is how communities are formed these days, via the internet. And I think all of us know, especially now when we start looking at our vaccination rates, what age population are we struggling with misinformation? It is this age group. And it is this age group that, again, although we say they're young, healthcare, as we can see today with vaccine hesitancy, with our ICUs being overflowed, these are the people that we need to be reaching. And in response to all this, Mayo published a wonderful, actually, white paper in October 2016. And I just wanted to highlight this one quotation that talks about the moral and societal duty of an academic healthcare provider, and I would even scratch out the academic, I'm just going to say healthcare provider, is to advance science, improve the care of his or her patients, and share knowledge. A very important part of this role requires physicians to participate in public debate, responsibly influence opinion, and help our patients navigate the complexities of healthcare. And I will tell you that in today's world, with our patients, part of navigating the complexities of healthcare is navigating the complexity of information that they are seeing and reading and hearing from their communities and from people on the internet. And on an organizational level, our hospitals have recognized this. Almost all hospitals have a Facebook page, with the majority as well also having a presence on Twitter, because they realize, again, patients are using the internet to help them make decisions as to where they should go and to whom they should see to have their surgery. And in fact, from an educational standpoint, residency programs have noticed this as well. Medical students, they are going to Twitter, they're going to Instagram. They want to see what is their life going to be like as a resident in their program. And now almost half of all residency programs have either a Twitter or Instagram page. So now what? So what am I really asking you to do? At the very least, I'm asking you to acknowledge that your patients are using resources, some of which are good and some of which are very much not. Your patients are trusting people other than you, and I think we all know this to a certain extent, but they're even trusting people beyond their family, beyond their friends, beyond their coworkers. They're trusting people they've never met to provide them real medical information. And so what I am inviting you to do is to open the dialogue with your patients. When you have a patient in your office, you're discussing a surgery, you're discussing a new diagnosis, ask them, where else are you getting your information? Do you have a support group? Would you like a support group? What resources? Who's been your support system in this process? Because part of it too is engaging with them and doing your own research, hearing from them where they're getting their information. Then you going and doing your own research on those websites, in those groups, to figure out, is this a good place for my patients? Because then once you've done that, you can help provide your own reliable sites. You can help give them resources that you feel comfortable with them using, because they're looking for it and they're going to find it, whether you give it to them or not. But what they find may not be what's best for them. And that's really where I think our role comes in. I think beyond that, there are obviously lots of ways to participate, influence, and engage, even on a departmental or practice level. Websites, communication, newsletters, blogs. There are lots of Facebook groups with societies. SAGES has one, International Hernia Collaboration, where it's really about building a network and support system for yourself, even on a clinical level, as well as Twitter and online journal clubs. Again, these are online journal clubs which are open to the lay public, and they can see us interacting and discussing things that affect them directly. I love this quotation, because to stay on the map, you have to keep showing up. And our patients are on a map. And the landscape of medicine has absolutely changed. But because it's changed, we can't stay off the map and just point at it and say we don't like it. This is dumb, this is silly, we can't do this. That's where our patients are. We need to meet our patients where they are, and we need to help support them in the best way possible. And even more than just belonging on the map, we need to participate. Thank you very much. I look forward to questions at the end.
Thank you. Our next presenter will also be virtual. Sharmil Disseminating is the Distinguished Professor and Peter C. Cannizzaro Chair at Texas Tech Health Science Center in Lubbock. Her clinical practice is acute care surgery, and she also currently serves as the chair of the ABA Verification Committee and as a governor on the American College of Surgeons. She will be discussing social media and surgical leadership.
Hello, everyone. And I am very sorry that I'm not there with you in Hawaii. I wish I were, but life is as it is. And so I'm still glad I get to join you virtually and talk a little bit about the importance of social media for surgical leaders. Let me share my screen here. Okay, so I really don't have any conflicts of interest that pertain to this talk. It is going to focus a lot on Twitter, because that is the medium that is most used by surgical leaders, actually most medical leaders. It really is. Twitter is a whole thing. TikTok and Instagram definitely used, especially by the younger among us. I don't fall in that category by a long shot anymore. And so the trainees are on both modes, for better or worse. WhatsApp is used more internationally, not so much in the United States. And Facebook really remains primarily a social medium, not used very much for surgical leadership and advancement. However, there are several important physician groups that do serve as an interconnected network. The Physician Moms Group, for example, is over 50,000 members. And these really are powerful ways to gather people. And so I think that should be recognized. But in the surgical field, a lot of this is focused on Twitter. So one of the things before we go into this, I think it's important to realize is that unless someone is paying you to do something, it's a hobby, not a job. And I've got some links at the bottom there. This recording should be available to you after the meeting as well. It's by Elizabeth Gilbert, who wrote Eat, Pray, Love, has a really nice little video about the distinctions. And basically, here's the way to think about your life. A hobby is something you do for fun. It should be zero stakes, painting, art. A job of this lot, this is actually the only thing you have to have because you're exchanging your time and your effort and your expertise for money. You've got to pay the bills. That's what a job does. A career is a job you're passionate about. And hopefully for all of us, that's surgery. And a vocation is a calling and something you cannot not do. And truly, it's taken a while, but I've realized for me, clinical surgery really is a calling. When I'm, as I currently am on my admin time as chair and I'm in my office for a week, usually after about day 5, I find myself wandering down to the surgical ICU, the trauma center, the OR, going, hey, what's going on? You know, trying to see if there's any way I can help, go scrub it on the case, see what's going on. I really can't not do it. And I've realized, you know, that's how you define this as a vocation. It's really so integral to your well-being and happiness that you couldn't not do it. And it's lovely when your job, your career, and your vocation all coincide. They don't always. Now, social media is what I call a hobby with benefits, because while it should be viewed as a hobby, it does really provide value in staying informed and connected and up to date. This helps as a citizen. A lot of the issues around racism in the United States that kind of exploded over the last few years, specifically in terms of the interaction with law enforcement and race, as a citizen, really were pivoted by social media, or at least were amplified in good stead. As a physician and as a leader, it really does have some advantages beyond simply being a way to spend time. And we'll go into that here in a second. For the purpose of this talk, I'm really going to focus on those latter 2 roles. So let's start with as a regular surgeon, without any leadership role or aspirations to it. There's still some benefits right there. And the first one for me is it can actually help your patients. And so this is a tweet by Emily Porter. She's actually the sister of Katie Porter and a physician in Texas. And she's really talking about how someone else, an ER physician, is crowdsourcing transfer capability for their patient who has a very severe illness, not COVID, but can't get ICU care because, of course, as we all know, as I sit here recording this, we have no ICU beds in Texas. And a lot of hospitals don't have surgical capacity. A lot of them don't have regular medical ICU capacity. And this is the situation. And this patient actually that she refers to did find a place to go out of state through this Facebook post. So it is quite powerful to help patients. We can have a whole hour-long talk about should physicians have to resort to social media to care for their patients? Obviously not, but it was an avenue that otherwise this physician had no access to. Another group on Facebook, the COVID-19 physician group, really served as a way to both vent and de-stress a little bit. One could argue maybe it increases the stress because we see everyone else's stress, but it also served as exchange of information. And this is a Facebook group as well during COVID. And I think COVID really highlighted some of the benefits of social media because it showed us how quickly we could communicate and share knowledge. By the time you wait for peer-reviewed publication to get printed and in your mailing box, it's way too late. Whereas with Twitter especially, and somewhat with Facebook, I found that I was able to read the latest paper that was published in the New England Journal or the Lancet or wherever it was on a particular new finding with COVID. And really it kept you up to date far beyond those of your peers who were relying purely on traditional media. You learn new techniques, and this one I love. So I learned how to do pie crusting on Twitter. We're quite open about it. Yelena Bogdan, I think, is the first one I saw doing it. She's an orthopedic surgeon. And, you know, I saw some of these posts like this one. And I went, well, that's a good idea. It's nicer than skin grafting. I'm going to try that. It's obviously very simple. Any surgeon can figure out how to do it from that image alone. And it works. And so then I went ahead and showed some of my results in similar fashion. And other people went, hey, no one taught me this. I'm going to do it. Literally never heard of it, never mentioned during my training. And really, I haven't seen this discussed in much of our meetings. And so with 2 seconds of reading a tweet, you can learn something new that maybe you otherwise wouldn't have access to. And I think a particular benefit is you're learning from other specialists, right? I don't have a lot of orthopedic surgeons in my surgical meetings, whereas here I can learn from different specialties about something that has great applicability to my own field. You can share your own research. So this is a paper that I did that Emmanuel Gutierrez, a surgeon out of the country actually, is sharing, and then I kind of amplified that. Because while a lot of people now have heard of the concept of subtotal cholecystectomy, a lot of people, and by people I also mean people taking the oral boards, people who graduated general surgery, cannot actually describe how to do it. And so to amplify something that I think is helpful, you can use Twitter, and actually a lot of people did see this. And a lot of people contact me saying, hey, I have a PDF and those images saved on my phone so I can use it. And it's really nice to know that something you've done isn't just sitting in a library somewhere collecting dust. People are using that knowledge. One thing I haven't ever used it for, but I think is a good use of it, is raising money. East has done a great job. Jeff Namias actually led this particular campaign, and raised actually ended up with over $100,000, I believe, to support future trauma care leaders. Clearly a great motive, and they did it all through social media. And finally, you can network and you can collaborate. And so this was a little call I put out some months ago for a multi-center trial. And as a result of some emails, but really mainly this tweet, we now have surgeons from across the world. I would not probably have reached surgeons in Colombia, in Switzerland, Sweden, if not for social media. And now from all over the world, we have over 60 surgeons collaborating with us on what is hopefully a really nice snapshot of real world practices in subtotal cholecystectomy. So, you know, it is really a great way to network. It allows people, regardless of hierarchy, to have access to other people of different hierarchies. It breaks down that barrier. It helps flatten our connections. And I think as a surgical leader, that's usually important, that we can include new surgeons, people who just started their practices, and they can be on an equal footing in a network like this to some very senior surgical leaders. I just want to show this. This is the COVID Surgery Collaborative. They actually, you know, included every person who contributed as an author. And so, you know, you can argue about whether being in the Guinness World Record book matters or not. But regardless, this is a collaborative that would not have happened again without social media. And it allowed data to be gathered quickly during a pandemic, which otherwise might have really not happened. So those are the benefits as any surgeon. I would encourage a lot of you to at least dip your toe in and see if this works for you, because again, it's a hobby, but it's a hobby with a lot of benefits. So as a leader, how does this play in? I really find that I can get up to the minute expert info. Obviously, you have to watch what you're reading. I'm not reading some of the crazies out there. There are people like that, but there are experts who can actually give me up to the minute info and help me make plans. Truthfully, I made plans for the Delta surge ahead of some of my peers because, and by peers, I mean other chairs, because of social media kind of telling me which way this was blowing and what was going to happen. I was able to put in some steps that helped us preserve surgical capacity and minimize the impact on our surgical patients during the surge. So that's a real benefit as a leader, to have that information coming down the pike, maybe a little sooner, to get a sense of how effective is vaccination, how much are the kids affected, how much are they taking at home based on what other people are going through, and to then be able to predict how this is going to evolve and put in some safeguards before it happens. I've found that very helpful as a leader who has to make some difficult decisions. Advocate for public health. So this is me getting my colonoscopy. And it was funny, you know, I was kind of bored, you're sitting there waiting. And so I put out this tweet, and you know, when you look at the likes, it's not a huge number, it's decent, but look at the impressions. 350,000 people nearly saw this. I would say that there's nothing I do, including this talk, that's going to get 350,000 views, right? It just doesn't happen. And of those 350,000, 16,000 actually interacted in some way, which means it caught their attention. They didn't just scroll by. Again, I can't reach 16,000 people with a public health message in almost any other format, honestly. So I really think that as leaders, we have an opportunity to use our platforms, some name recognition, to advocate for good public health measures. And then making your own place look good, publicity and recruitment. These are some people doing it really well. I can tell you, Los Castron in Arizona, really highlighting some of the wonderful work they're doing. There's a resident talking about how excited he is to be at his program. I can tell you, there is no amount of money that pays for publicity like that. And then there's the Chicago surgery residents talking about how great their department chair is. That's clearly a huge recruiting tool. And they're doing this genuinely and spontaneously. It comes across much better than an orchestrated public relations endeavor that you pay for. If nothing else, I would say that as a surgical leader, or even as a surgeon, just having name recognition and familiarity with your face actually counts, because as humans, we are primed to consider people who we have seen before or whose names we recognize more favorably. This has been well documented. Unless your name recognition is irreversibly related to something terrible or bad, short of that, it is a positive thing to just have your name recognizable. And so if nothing else, being on social media definitely achieves that if you get any sort of presence at all. So I'm going to come back to what I said at the beginning, that social media is a hobby, not a job. And the hobby is supposed to be zero stakes, right? You remember that part? So here's the catch. Is social media really a zero stakes endeavor? And I'm going to say, oh no, it is not. It's a jungle out there. One of my favorite pieces of art by Margaret Keane. In the internet, it looks more like this. There are trolls everywhere. I mean, I can post about how the current Delta surge is reducing surgical capacity for people with surgical emergencies. This is terrible. And somebody will pop up going, you're lying. We have plenty of beds. It's just we don't have nurses. It's because you all are so terrible to nurses. And it's kind of like, okay, it is impossible. You cannot interact in any way and not have the trolls get you. So firstly, don't feed the trolls. There's no point in engaging. It really is pointless. Block liberally, ignore whatever you want to do. But there is a real risk that you will say something stupid. We all do, right? I've done it plenty of times. But if it goes viral on social media before you catch it and delete it, it's there forever. And maybe it's out of context, and maybe you said something really silly that you later regret. I promise you, that'll be the one thing that people really notice. So it isn't zero stakes. And the higher you go, so the higher up the leadership ladder, the harder you fall, the more the consequences of one careless comment. So these are some safety checks. I'm not going to spend a lot of time on it. Pause before posting. If you are even a little bit worried about it, just don't. Never, obviously, violate HIPAA. Don't include patient identifiers. And this includes things like summarized sword to the chest. That's unusual enough. That's an identifiable presentation. I always like to say keep at least a few days, if not weeks, between you seeing the patient and posting so no one can identify it. That's just a good general rule. Please don't post gory pictures just for that sake. Drives me nuts when I see trauma injuries, femur sticking out just for gore. Please don't do it. Trauma porn is really distasteful. Don't do it. My general rule, if you wouldn't say it in a billboard, don't say it at all. That one's kind of the bar. And the last one is important. Your perception, your intention is not what matters. It's how people perceive it. A photo in the OR holding a specimen may seem innocent, but it really kind of is a bit distasteful. It comes across as if you're holding up the Heisman Trophy. It's not a good look. So even if it's not technically a HIPAA violation or violating rules, it can give that impression of, do I want my surgeon stopping the operation to pose for a photo? No, really not. So be mindful, be thoughtful. And it's good to post educational images and teach people. That actually most people understand, like a specimen well draped out, laid out on a table, taken a photo, clearly not interrupting the procedure, it was done afterward, and explaining, hey, look at this. This is an important finding. Learn about this. That's fine. You holding up a specimen, not so much. So be aware of how you're coming across, not just what rules you're breaking or not breaking. And so this is a statement from the American College of Surgeons on guidelines for ethical use of social media. I think it's phenomenal. I'm also terribly biased because I wrote it. So take that for what it's worth. But I really am hoping this can help some of you at least navigate this terrain, which has some pitfalls. There are some landmines in here, but also a lot of benefit. So thank you for listening. I think that social media is here to stay. There are real world benefits to it. We need to be careful, but we do need to engage. So with that, I hope you all are enjoying a wonderful time in Hawaii. Wish I could be there with you. And thank you for listening.
And our last speaker of the session is going to be Sean Langenfeld. He's an associate professor of surgery at the University of Nebraska, where he's the chief of colon and rectal surgery, has clinical interest in colon and rectal surgery, social media, and online reputation management. And today, Sean will be discussing social media and research.
I just lost 4 more out the door just now. I'm a little intimidated by this audience. For the people on virtual format, standing room only. I recognize that I am the last thing standing between you guys and either the beach or the golf course, but I am going to strut and fret my hour upon the stage because that's what I like to do. Now, I know what you're thinking. Social media is not for research, it's for arguing with strangers. And you're wrong, and that's what I'm describing. But first, some disclosures, okay? So in junior high, I broke up with my girlfriend, Kate, via pass note. I started dating her friend just a few days later. Even more recently, last month, I emailed a coworker to congratulate her on an award, but I didn't hit reply all. So basically, I did nothing. And then last week, I lied to my son, told him I didn't know the password to unlock his iPad when he reached his time limit. I knew the password, but he went outside, nobody got hurt. But I don't have any financial disclosures. Other research can mean a lot of things. We talk about researching social media. We can use social media to conduct research. Maybe patients doing their own research. I think we call those Karens now. And then probably the most effective thing, which we'll talk about, is promoting and disseminating, debating research on social media. And then Dr. Disseminating talked about this a little bit, but you can use it to make clinical decisions and learn new techniques. I'm probably going to talk about the more negative side of that than she did. But before we do that, we have to understand some fundamental points about social media. And thankfully, Dr. Coleman saved me some time, went over a lot of this. The first one is social media is very powerful. Now, my sister tells me that Facebook is dead. Now, she's 20. She's half sister. But despite that, the revenue goes up every year. It's $90 billion, 2020. Twitter, we already talked about how many people use that. Instagram, the younger platform, 67% of Americans under the age of 30. But when we think about social media, you have to remember the accuracy of this is not guaranteed. So the content that you see online is not subjected to rigorous peer review. It's just basically expert opinion if you're lucky. Because really expertise is not required to give an opinion. If I'm loud and confident, people will assign value to me, probably more value than the soft-spoken true expert. Some examples, some experts I found on Facebook and some of these groups I'm in. One guy said that, I'm so good with the robot, I'll do diverticulitis surgery after one attack, because the outcomes are so great, which is, deviates from the standard of care. I had another guy on the Robot Surgery Collaborative say that he intentionally creates a narrow ileocolic anastomosis to recreate the valve. And I threw up in my mouth a little bit when I saw that. All you really need is an audience. So I got about 3,000 followers online. I think it's going to be even higher after this talk. And American College of Surgeons has 72,000. But Dr. Oz, love him or hate him, has almost 4 million. Jenny McCarthy, with all of her opinions about vaccinations and autism, has 1.2 million. And there's 70 million people that want to hear what Dr. Kardashian has to say. And so certainly expertise is not needed. And the players are poorly defined. This is John Thompson. He's not here. He's still in Omaha, so I put him on the slides for it to be in spirit. I'm sure you guys would recognize that he does not have his own Twitter account. He's not a big social media buff. But I can go on Twitter tomorrow and create a handle, and I can post whatever opinions I want, masquerading as the chief of general surgery. Who reads these comments and how much weight they assign to them is very difficult to predict. And then the final thing, whenever we talk about an audience for research on social media, is they didn't come there for the studies. There's a lot of platforms right now that don't get a lot of action unless they want to talk about diversity, equity, and inclusion in a negative manner. That's what the ACS Communities is for. Otherwise, most of these are ghost towns. The reason they're ghost towns is because you have to log in. Facebook and Twitter allow unparalleled surgeon engagement because there's no need for intention. You're already there. You're posting memes and liking family photos, and you stumble across a survey or a surgical video. Now, these people didn't make the choice to open a journal and read its contents. And the reason that's important is you have a bigger audience, but you don't necessarily have a captive audience. So moving on to the actual meat of the talk, researching social media. I've been talking about social media in the podium since about 2014. I want to get invited. I'm just putting it out there. Dr. Katari, I want to get invited. Rectal cancer, IBD. I am an expert, but it's always social media. That being said, the reason that's important is 3,500 already seemed like a big number to me back then. But look at how that's ballooned up. Now, the more recently, 36,000 publications on social media, peer-reviewed on PubMed. If you combine the topics of social media and COVID, just as many results as there was in spring 2015 overall. So it's blowing up. And I will fully admit that I have done my own research in social media. This is sort of how I got involved in all these podiums. Most of what I do is talk about people screwing up online. I think that that's been covered in the previous talks. You can use social media to conduct research too, and this is common. And it's a great way, if you want to shotgun blast out information and reach a big audience without spending much money, it's a great option. You do surveys, you can recruit physicians or patients to studies, you can network between researchers, but there's some very important limitations. First of all, the biggest one, take-home point, is sample bias. What are you seeing online? It's not necessarily the targeted demographic. Poor quality and poor oversight of all information you get. And then most of the data that you can accumulate online is very difficult to verify, which we sort of talked about already. Now, there is something that I'm a big proponent of when it comes to social media research, and that's promoting research through social media. This is a powerful tool to bring attention to your published work. These are called visual abstracts at the bottom. I'm sure a lot of you guys have seen these on different platforms, but essentially what it does is have a very distilled visual summary of a study that's supposed to bring people to the website to read the article. Now, some will say that they don't actually ever read the article, they just share, but we talk about that later. But there's actually a whole new thing outside of impact factor that we use now called altmetrics to sort of measure how much buzz a hot topic gets online. And this is actually something people use when they're doing promotion and tenure. Social media is wonderful if you want to promote yourself. It's a great tool for that. You can see me talking about ACS talks, or I validated an anal rectal simulator and then gave a talk on reputation management at Sages. The reason it's so effective at promoting yourself is it's sort of an inherently narcissistic concept, if that makes sense. I don't know if you guys agree with me or not, but I think self-promotion on social media is ubiquitous. And so now that being said, unrelated note, don't forget to follow me on Twitter and Instagram. But learning about surgery online, this is something that I'm sort of really conflicted about, because I think it's a wonderful tool. If you think about the way it's revolutionized surgical education, you can stay up to date on the literature through the visual abstract we talked about. Dr. Coleman talked about journal clubs, wonderful. You can also go on YouTube and watch videos and learn a new technique, and you can follow national meetings from your living room using the hashtags. It's wonderful. And then probably more important is not everybody has a John Thompson 2 offices down that they can bounce hard cases off of. And what you have with social media in some of these closed groups is a virtual surgeon's lounge where the less experienced surgeon can get like near instant expert opinion. I think it's a great tool. It's just some examples of that. This is a Facebook. I think actually closed Facebook groups are a wonderful thing. I know that the other platforms we've talked about more, but this is where a lot of discussion goes on. Dan Popovich is like a mini celebrity in the Sages group. The problem though, when you think about all these groups and the people that say, this is what I would do, or in my experience, is the social media experts very poorly defined. I don't know whose opinion to value the most. Is it the loudest person, the biggest follower count, maybe the greatest number of cool YouTube videos? We really don't know the credentials or the experience of these people. And a lot of them are kind of faking it till you make it, if that makes sense. I've had a lot of people say, in my experience, and they're like 3 days in practice. And then certainly the biggest problem here is that nobody talks about conflicts of interest. Just for fun, I encourage you guys, after you see somebody make a comment, go look them up in CMS Open Payments, because they're not disclosing it. Now, technical innovations. She talked about that in the last talk, because I don't want to dismiss that. It's great. But what do you guys think about learning a technique after watching it on a YouTube video? How many patients are in the series? Is there any true follow-up, any comparison to standard care? Are we sophisticated enough to learn a new complex technique after watching a YouTube video? The reality is in these groups is nobody ever posts a negative experience. Every patient had the best outcome possible with the new technique. And I don't know how safe that is. And so I'm actually not a big fan of that, to be honest. And then we talk about people doing their own research. It's getting to the point now where there's a subset of people in these social media groups who don't trust peer-reviewed literature anymore. They trust the advice from these stupid Facebook groups more than the textbook, because they go, oh, that's not my experience with my patients. And that's a very dangerous way to interpret literature. So do they mix? Absolutely. It's part of everything we do, including research, but there's a lot of misinformation out there, both deliberate and otherwise, and there's a ton of background noise, and so bias is sort of rampant. So in conclusion, and as you guys can see, I made up some time in the air in case we want to have discussion before the beach or the golf course. There's important aspects that remain poorly defined. It's safe to consume, but you got to maintain a pretty healthy level of skepticism if you're going to do research online. That's all. Thank you.
All right, we can go ahead and open up for questions. Any questions? If not, I have several jotted down. I'll start with Bridget. You know, Bridget, and you and I've talked about this in the past. You know, how do you get that concept of what palliative care is out of people's heads? I've always joked that most people hear palliative care, especially surgeons, and they think you're coming to trip over the ventilator plug and be done. And it's a lot, like you said, it's a lot more. So how do we change that perspective? Because I think that's the key to this from a surgical perspective.
I think at the institution level, it's having a physician champion. I tell people, ask me, how does that go together? How can you be a surgeon and do palliative care? And I said, nothing says aggressive care like the surgeon coming in. And it also means that I have all the tools for palliation in my tool chest. I can hopefully communicate effectively, but I also am going to aggressively manage your pain. And if it's an operation that's going to be the thing that helps you get to your goals of care, I can do that too. So I think I have some leverage over my non-procedural colleagues that way.
And to that point also, just, you know, you're the director of surgical palliative care. I mean, would you think that all departments should ultimately have something of that nature? Obviously, you have to have someone that's got the expertise and interest, but it makes a lot of sense.
I think so. And I think that it's probably already there. You know, there's definitely a shortage of palliative care providers. So I'm not talking about subspecialty trained folks, but I think that there are enough people out there that sort of have an inclination or a bias toward it, that with some additional education and training can sort of be that resource to at least just bring it up. And I think that the ACGME, and for those of us that work in medical education, it's a requirement. So I think that we're trying to put some leverage behind it, that it's a real content area that people need to have some expertise in. The American Board of Surgeries, God bless them. Now there's questions on the certifying and qualifying exam about palliative care. So it's not a fringe thing. You got to know, just the way you should know about how to do informed consent.
Excellent. I mean, I think everyone knows my bias on social media after my talk yesterday, but I guess a question for Jamie. I mean, and you guys all kind of alluded to the pros and the cons, which I can appreciate. There are pros, but I think you all kind of talked about no content control. You don't know what's out there. And I mean, I think think about the politicization of COVID, vaccines, hand washing, social, everything, and what that's done. How do you remedy that?
Tell me what you mean, but how do you remedy the fact there's no quality control?
Yeah. And especially our patients are going there for information.
I will share my opinion only because it's something I talk about a ton. It's very hard to get rid of bad information on the internet. The better approach is to provide good information, and you have to manipulate the Google search. You have to understand Google Analytics and make sure that, you know, whatever bad information out there is further down the Google search, because what we know about the American public, she talked about how people are using it. We also know they have a horrible attention span. So 50% of people don't go past the first 3 results in a Google search, and about 90% don't go past the first page. And so I think the secret is to have big groups that have, website designers that understand search engine optimization, provide positive information. And that's what she was saying when she was talking about getting involved, because that's how we do that, in my opinion.
And, I 100% agree. It's a void. Something's going to fill it. And so I think that there's a choice where you can sit on the sidelines and say, yes, there's all this bad information, or you can do your part, which is, even if you're not creating the content, but helping amplify it, helping good information get to where it needs to go. And I think, again, it's really opening that conversation with your patients and asking them, where do you go for medical information? What sites are you using? And then getting familiar in your own area with good communities, good resources, good websites to really help direct them, because they're looking for it. And we can trust Google with good search engine optimization, or we can engage in that, even if we don't have our own accounts, even if we aren't creating content. It's being social media savvy, which I think our patients do absolutely need us to be.
And then I don't know if Sharmila is on. Chris, is Sharmila?
I am, yes. Hi, Rob.
Hey, Sharmila, how you doing? Just a quick
Good.
question.
Am I like the voice of God beaming over?
I mean, you talked about the risks, and I'm kind of wondering the risk benefit. How do you do the risk benefit as being on social media? Because you kind of showed all the potential pitfalls, as did Sean. How do you wage that risk benefit ratio versus someone like me who's just like, I'm not going to be involved and engage, and then I lose all the risk. I don't gain the benefit.
Absolutely. I think, Rob, much as I advocate for doing it for all the positives that I highlighted, it is ultimately, no one's paying you to do this. It's a hobby, not a job, and there is risk. So if you don't want to do it, then I think that's perfectly fine. And you can support in other ways, as Jamie mentioned, by being part of organizations that have, professionally vetted content. I think that, those guidelines of pause before you post, think what you're saying, and understand that anything you post, if it can be viewed negatively, it will. And think carefully about that. I think the flip side, though, one thing I don't want to come across as is that we need to self-censor. One of the things that you could talk about is how we should have freedom of speech. It's a fundamental tenet for us. And you should be able to put your opinions out about controversial issues like gun control. I mean, I do not censor my thoughts on that, nor on violence and racism and things like that. I think that is fine, and thoughtful, nuanced comments, even on controversial topics, that we would be willing to stand up to in, a packed audience in a town hall. I think saying that on social media is just fine. I think where you have to be careful is if you're frustrated or it's been a long day and you're venting, that's not the place. And so what I would say is don't self-censor, whether it's about medical or personal political things, but just say it as you would in a public meeting and just give it the same level of respect. And to me, that's the guideline I use. Some of the things I say people don't agree with, that's fine. But would I stand by it on a billboard? Yes. Then say it. And that's just kind of the billboard thing is what I use to guide myself.
Hi, Sharmila. It's so good to see you. I think to piggyback on that, I will say that for anyone who's really interested in getting involved in social media from a creation standpoint, so not just being social media savvy, but really getting an account, getting involved, is figure out your why behind it. Because you got to have a why behind any part of how we spend our time. And especially as Sharmila is saying, this, you don't get paid for this. Whether you have 50,000 followers or 500,000, to a certain extent, as a surgeon, you're not making money off of this. So what is your why behind it? And I think that helps provide a filter to me when, after it's been a long day, or I'm reacting to a news story, or I'm frustrated because some physician is, spouting some vaccine nonsense. It's not necessarily about self-censoring, because I agree with you completely. People respond and react to authenticity. But what it's about is filtering through your why. Does this post meet why I'm in this space, what I'm trying to accomplish, and who I really am as a person? And I think that for me is definitely ties in so well to your billboard comment. I'm going to have to credit you for that and promote it, because I do love that.
The last question I have is Chris on also, Dr. Kokenar?
I am, but evidently I can't make my camera work.
Hey, Chris, how you doing? It's probably for Chris and Bridget together. I mean, a lot of Chris, your talk when you're doing it, it really resonated with a lot of what Bridget had said. There's so much overlap. Obviously, palliative care is beyond just the geriatric population, but there's obviously a great extent of overlap. I was just kind of curious, is there a lot of crosstalk going on between those two organizations, and what does that look like?
Yeah, Ronnie Rosenthal's been a huge member of that movement for geriatric surgical care, as has Zara Cooper. So I think that there are definitely places of overlap between those two quality initiatives. And that's really been the signature piece of Dr. Hoyt's directorship of the American College of Surgeons, is on quality, and what does quality look like, and what does quality look like for geriatric surgery, and also really seeing palliative care as part of that venue for creating quality, because it's patient and family centered care.
Chris, any
And I
thoughts?
think the other person too that has had a lot of bandwidth on both areas has been Ann Mosenthal. And she's been another person that has very much helped push all of these things forward. And so I think there is a lot of going back and forth. even though I think palliative care is not something that is just for the elderly. I think it needs to be thought of for all ages, especially on the trauma side. And so it is something that there's a lot of overlap. And I think if we do provide better care for elderly, I think it'll come down to providing better care for everyone.
And one last question, I promise. Chris, just out of curiosity, I know the GSV is very recent. What's the traction been so far from hospitals, out of curiosity?
There is only one hospital that has been actually certified in either a level 1 or level 2 position, but there are a number of hospitals that are in that commitment phase where they are, I think, putting together that all meeting all of the different things that you have to meet to be able to get the level 1 verification. And so you have quite a few hospitals that are in that phase.
Well, thanks, Chris. And I'd like to take this time to thank all the panelists for an excellent session, and everyone go enjoy your afternoon. Thanks so much.